Hello, Covai Post viewers. We are witnessing an increasing trend of youngsters falling a prey to stroke. What exactly is the reason? Smoking is predominantly the reason, says Dr. K Vijayan, the neurologist of Royal Care Hospital. And what else are the other reasons? Let us listen into him. So, thank you so much for talking to Covai Post, Doctor. Doctor, we are hearing that there is an increasing trend of youngsters falling a prey to stroke.
Of course.
So, besides smoking, what are the other predominant reasons?
Okay, stroke by itself, the incidence is increasing.
Okay.
Not only youngsters, all over, through all age groups, the incidence is increasing. Now, youngsters, if I say the commonest condition, youngsters and beyond.
Okay.
Any age group, it's smoking.
Okay.
There are some avoidable risk factors which you can avoid. There are some risk factors which you cannot avoid.
Okay.
Now, one of these avoidable risk factors is smoking, alcohol, and tobacco chewing.
Okay.
So these three are easily avoidable risk factors. 3. 2, the other 2 avoidable risk factors are hypertension and diabetes.
Okay.
Now these are also very important risk factors. How to avoid them? You cannot avoid them totally, but you can prevent and you can control them.
Okay.
By keeping them controlled, the chance of stroke is much reduced.
Okay.
But if you avoid smoking, if you avoid tobacco chewing, if you avoid alcohol, then the chances of you getting a stroke are almost nil.
Okay. So, how many cases do you witness in your practice, doctor?
In my practice, almost
New cases, maybe
almost a new case every day.
every day.
Every day a new case. This is across all age groups, of which I would say
So,
at
could you
least
give me the range of the age group?
across all age groups, maybe starting from 10 up to 80, 90,
10?
even 100.
What is the reason for 10?
Now there is a genetic factors play a role.
Okay.
But most often when we see youngsters with stroke, predominantly it's the blood vessel that goes to the brain. The main blood vessels. There are 4 main blood vessels, 2 in the front and 2 behind.
Yeah.
Now these 4 main arteries can get torn apart.
Okay.
What we call dissection. They are built in layers, you see. They have layers. There are 3 layers, of which the internal layer alone can tear apart.
Okay.
That's what we call dissection. Now that occurs commonly due to like say straining, extreme postures,
Okay.
excessive exercise, too much of neck movement.
Okay.
We've seen, for example, this occurring after they go to a water theme park.
Oh, really?
Sometimes the theme park,
Okay.
they go for a what do you call that? The one that goes through
the slide kind of a ride.
Yeah, that ride, especially that can cause tearing away of the inner layer, and
Okay.
that can cause a stroke. Now that's called dissection. That can cause a stroke in younger age groups. Genetically, you can get strokes. You have holes in the heart, you can get a stroke at a very young age.
Okay.
Now, if you have, for example,
So
it may not manifest as, it's not all of the brain.
Okay. So, stroke is not all of
the
brain.
brain is the organ that is affected.
Okay.
Now, the bullets come from somewhere
Okay.
around. Now, you can have, from birth, they can have a problem with their blood clotting too easily, and that, suppose you have somebody with a blood who has a tendency for blood to clot easily, then he has a dehydration. For example, he has a diarrhea, he has a severe vomiting, then he is dehydrated, and then this is the second insult.
Okay.
Then that will produce a blood clot.
Okay.
This blood clot can occur anywhere in the body. Usually it occurs in the veins.
Okay.
It can occur in the veins of the brain, it can occur in the veins of the legs. Now,
Okay.
this youngster has a hole in the heart, what we call a PFO, a patent foramen ovale. Then this clot can migrate across the heart. Usually the clot gets trapped in the lung. It won't go beyond. Now this clot in the vein can go across the hole in the heart, what we call patent foramen ovale, and then reach the brain.
To the brain.
Now that is another common cause for stroke.
Okay. So, doctor, with the increase in the number of stroke patients, as you had mentioned, how exactly are we equipping ourselves in terms of the facilities as well as rehabilitation?
So the first is prevention of stroke. Now, how do you prevent a stroke? First, you take care of the risk factors, which I told you already. And apart from this, you have lots and lots of other causes for stroke. Now, stroke is not only due to clotting of blood in the brain. It can also be due to bleeding or hemorrhaging inside the brain. It can also be due to a clot which forms within the veins of the brain. So there are 3 reasons for stroke apparently. In the case of the heart, you have only one reason. It's always a clot that blocks a vessel that supplies the heart, and that part of the heart is affected. We call it heart attack. Similarly, we call the stroke attack or brain attack, but this can be due to many reasons. 80% of the reasons is due to a clot in the blood vessel, blocking the blood supply to a portion of the brain. Now the manifestations are different because the brain controls each and every part of the body. It makes you think, it makes you speak, it makes you laugh, it makes you work. Everything is controlled by the brain. It makes you see. So everything is controlled by the brain. So it even helps you to stand properly, walk properly, sit properly. So it can range from a catastrophic event like everybody, you and me, can recognize. Something like a patient has a paralysis of one half of the body.
Right.
So patient cannot smile properly, patient cannot lift his hand, patient cannot lift his leg. Now of these 3, if any 2 of there, then it's a stroke.
Okay, speech impairment also, doctor?
Speech impairment, anything. So speech, smile,
right, okay.
hand and leg.
Okay.
Apart from this, some people may have what we call TIAs or warning attacks.
Okay.
These warning attacks, usually we see in 40 to 50% of them, they occur about 2 weeks before the onset of the major stroke.
Okay.
These warning attacks are the ones which we'll have to concentrate on. What can these warning attacks be? There can be slight numbness of your hand. As soon as you wake up in the morning, you walk, you feel slightly dizzy. So what's happened to me? Slightly dizzy, few seconds later, you become all right, absolutely all right.
Okay.
Or you go to reach out for a cup of coffee, you're not able to hold the cup of coffee, your hands, your fingers go numb, then you're not able to hold, then you do something and 2 seconds, 3 seconds, it becomes all right, then you again start drinking the cup of coffee.
Okay.
Or you start speaking, suddenly you go blank, you're not able to speak, you search for words for some time, and then again you get back your speech. Now this is a warning attack. All these are warning attacks. Let me put it this way. Any negative event is a stroke. For example, if you can't do something which you've been doing already.
Okay.
And if it lasts
That
for
makes it
few
simple.
seconds.
Yeah.
Any negative event, you're not able to move, you're not able to speak, you're not able to think, you're not able to swallow. Any negative event which lasts for a few seconds, for example, let's say 5 seconds, 10 seconds, and goes off, don't neglect that.
Okay.
Now
That's important.
that's very important. Now if you go to the hospital with these symptoms, and then they'll do a battery of tests. If you do all these tests, then you may identify a block in the vessel supplying the brain. You may identify a cardiac problem. You may identify a primary brain issue itself, a primary problem in the brain itself.
Right.
For example, patients with tumors also can have these symptoms.
Okay.
So there are chances for picking them early. Now, if you pick them up early, then the chances for totally preventing the stroke.
Okay.
But if you allow it to progress, then you say, now this may come and go, then again it may come and go. But you may neglect it for the first time, don't neglect it for the second time.
First time, yeah.
Second time, definitely don't neglect it.
Yeah. So, doctor, could you tell us a little bit about the treatment for stroke, the facilities and the rehabilitation thereafter?
Treatment, as far as treatment of stroke is concerned, stroke should be treated like a heart attack.
Okay.
That's why we call a stroke
So it's
a
as
brain
serious
attack.
as that?
It's very serious. It's more serious than that. Why do I say more serious than that? Because that's the time period when we can completely cure the stroke.
Right.
If somebody has a stroke, paralysis of one side of the body, if he reaches the hospital within 6 hours, that's the period.
Golden hour.
Yeah, golden period where you can definitely cure him of the stroke.
Okay.
Now, when I say 6 hours, each and every minute is important.
Right.
So don't wait for 6 hours. Now, somebody has a stroke, rush him immediately to a facility which has a comprehensive stroke care. Now, we run a comprehensive stroke unit. Comprehensive in the sense that it's a complete unit.
Okay.
As soon as the patient arrives in the emergency, then immediately we raise a code, we raise a stroke code, and immediately everybody gets notified. The neurologist on call, the radiologist on call, the CT, and the emergency physicians. They all get notified at the moment as soon as the patient has a stroke suspect.
Okay.
We don't even, just a stroke suspect, that's all. we raise a code, immediately there is a stroke code. And within minutes, the patient has 2 IV lines inside, basic investigation, and within 5 minutes, 10 minutes, he's on the CT table.
Okay.
The next thing is investigation we do is a CT scan. If we say there is no bleed, then the next, before the next investigation, we start treatment.
Okay.
The next investigation is what we inject a dye into the patient's vein and to see whether there are blocked arteries. But when the radiographer is preparing this, he has to prepare the contrast, everything he has to prepare. Before injecting, we start treating the patient.
You start treating him
on the CT
stroke.
table. Yeah, we start treating. If there is no bleed, then we presume it's a block.
Okay.
We need not even presume, we know it's a block.
Okay.
Because we know, because this man is paralyzed on one side of the body, and this man has a normal CT scan. You go ahead, push the medicine.
Okay.
The medicine nowadays is very easy, though it's not that cheap. It's very easy to give. Anybody can get trained in it. In just 2 weeks' time, any fresh medico comes can get trained in it.
So it kind of dilutes the clot.
Yeah, it breaks the clot. Now, you should remember that the medicine not always works. It cannot work all the time.
Okay.
Now, what percentage does it work? It works in 40 to 50%. Yes, it works definitely. Small clots, yes, it works. But large clots, bigger arteries, this medicine may not work completely. It may work partially. Then what do you do with them?
Yeah.
What do you do? Then what we do is, as I told you, we push the medicine immediately, and then we come back and then do another CT scan to look for blocked arteries. We call what we call a CT angiogram.
Okay.
Now this is the protocol. Worldwide, this is the protocol.
Okay.
We do a CT angiogram. We find a major artery that is occluded. Suppose, for example, in the neck or in the brain.
Okay.
Now the brain, there are again 4 arteries, and the 4 arteries join together in the form of a circle.
Okay.
If one of these is blocked anywhere, normally what gets blocked is the middle cerebral artery. That's again 80%.
Okay.
80% it is a block. 80% of blocks are middle cerebral artery. Now you see that middle cerebral artery is blocked. You given the medicine, you push the patient immediately to the cath lab. Now where our next team, that's the interventional radiologist, takes over, he puts in a catheter through the artery either in the groin or in the wrist. And this artery is taken all the way up to the clot, and the remaining clot is also removed.
Okay.
We either suck it out, or what we employ what is called a stent, which
And
catches
this is done
the
under
clot.
anesthesia?
Usually we prefer not to do it in anesthesia, because we are there all the time monitoring this patient.
Okay.
We prefer that the patient is conscious at that time.
So local
We
anesthesia
prefer,
maybe.
yeah, this is only local anesthesia, only for the puncture.
Okay.
Most of the time, if the patient is stable, we would prefer not to anesthetize him. We would prefer not to sedate him. Maybe we give him mild sedation so that to enable the radiologist to do it. But we are there all around, monitoring his BP, monitoring his vitals, monitoring him also.
Right.
We keep monitoring, keep asking him questions. If he cannot speak, we ask him to respond by gestures.
Right.
So we keep doing this again and again. We never sedate the patient. We never go into a general anesthesia unless it is very important. Unless the patient is very see, for example, patient is very irritable. He doesn't cooperate with you for any of these maneuvers. Then maybe we need to put in a general anesthesia. Otherwise, usually we don't anesthetize the patient. And then immediately after that, if necessary, we do a CT scan or we take him to the ICU. This is called comprehensive stroke care. Now, the time boundaries have been shifting. Now, previously when this was introduced in 1995, time was 3 hours.
Okay.
Slowly they kept pushing the time boundary. In 2007 it became 4.5 hours. So it said up to 4.5 hours you can give the medicine. You give the medicine, no harm. Of course, there can be some harm, but the benefits outweigh the risk. Up to 6 hours, medicine is safe. Let's say 4.5 hours, it's
so by
definitely
6
safe.
hours, the brain artery or the vessel becomes what? Weakened? Worn out?
Yes, the blood vessel also requires blood supply. So it becomes worn out, and there are chances that it may bleed. Now beyond 6 hours, now the boundary is being pushed further. You can do, if somebody comes to us after 6 hours, say, then there, or after 4.5 hours, say, where you cannot give the medicine, then what we do is we try to find out, yes, this patient has a stroke, this patient has a blocked artery. Now we try to find out whether this patient has a salvageable brain.
Okay.
Now all that part of the brain that is supplied by this blocked artery doesn't get damaged. Part of it gets damaged, part of it remains. Why? Because the brain has a lot of collaterals. On its own, it has a lot of bypass pathways. Once blocked, these all open up supplying, but they won't be complete. They can sustain for a few more hours.
Okay.
Now, when they sustain the brain, you have to open up this clot. Now, this process to identify which part of the brain is salvageable or rescuable, now we have to do an MRI.
Okay. Okay.
And there we'll do an MRI. Sometimes this question you ask, there we may need to sedate the patient, we may need to put a tube through his mouth to ventilate the lungs,
right,
and then get an MRI done immediately. Our angio suit, our CT suit and MRI very nearby. So we do a CT, straight away shift to MRI to see whether there is salvageable brain. Now how much of this can be salvaged? Say even if 20%. Suppose this blocked artery is supplying, say, let's say 100% of this, and 80% of it is gone, but still you have 20%. That also can be salvaged.
Okay, so when it comes to salvaging brain, doctor, does the age play a role there?
I would say no. Age would be just a number. Yes, of course, age plays a role.
Okay.
But we don't bother about it. It's a relative contraindication. It's not an absolute contraindication.
Okay.
Now, we know of stories where we have thrombolized 100 years old, 82 years old, 87 years old. If there is a salvageable brain, that has to be opened up. The artery has to be opened up.
So, doctor, what after this initial treatment? What should the patient do?
Okay, after this initial treatment, then we try to assess why he developed this stroke.
Okay.
Now, treatment, we don't bother about why he developed the stroke. Then we try to assess. Now, most of these patients have a block in the artery supplying the brain. This is called the carotid artery, which supplies, it divides into two. It's this common carotid divides into two. One supplies the face, one supplies the brain.
Okay.
The internal carotid artery is the one that gets blocked by a cholesterol. Cholesterol. Long. Okay. So this can withstand, the brain can withstand as long as this is 70% blocked.
Okay.
If this is more than 70% blocked, then the brain will not withstand.
Okay.
Then that block or that block has to be removed. How do we do that? You have two ways of doing it. One is putting a stent in, just like we do.
Heart.
The other thing is just like you do a bypass for the heart. You do a bypass for the heart, but here you don't do a bypass. You open up the artery, remove the cholesterol plaque, sew it up again.
Okay. Okay.
Now, it may sound very simple, but it's not as simple as that. Here, then that is called carotid endarterectomy.
Okay.
You remove the inner portion of the carotid artery and leave the outer tube alone.
Okay.
The outer tube alone, and so that the block gets removed.
Yeah.
Now
the
this surgery, this surgery we have specialized in.
Okay.
We've done about 23 carotid endarterectomies as of date in the last 2 years. I wouldn't say last 2 years, last 1.5 years. Since our existence, we have a wonderful team. We have a neurosurgeon, we have a cardiovascular surgeon, and then we neurologists, two of my colleague Dr. Ramya and myself. When I'm not there, she's there. So we keep monitoring the brain when they do these.
Okay.
When they are doing this artery, they have to clamp the artery, block the flow, open up and sew it up again. And during this period, which takes about half an hour, sometimes even prolonged. So this is the gold standard. If you have a block, you have to operate. That is the gold standard. The block should be more than 70%, but that is the gold standard. What is the next? If you cannot operate, then you can do a stenting. You cannot operate, then you do a stenting. Stenting is not the gold standard. Operation is a gold standard, followed by.
So what is the risk factor?
The risk of doing this
operation.
The risk of doing this operation, you may develop a stroke itself because of the operation. But you don't develop it in 98% of the cases.
Okay.
98. If suppose you do 100 surgeries, only 2 surgeries may end up with a major complication. Most of the minor complications, they do get better. But if you do it under monitoring, most of the time we get away. We don't have to face this. But why you should do this surgery? Because you take 100 persons with this block, you follow them over 1 year, 26 to 30% of people will develop a stroke.
Okay.
Not a minor stroke, but a major
stroke. Okay.
You do the surgery and then follow them up for a year, then only 5% will develop. So it's a huge gap. So you'll have to do the surgery. Now this surgery is what we are specializing in. Now apart from this, after this what? Some people, we may not get a complete recovery in stroke. Then they all end up having stiff limbs. Then you can do something, yes you can do, apart from the general rehabilitation, exercise, physio, which is of course the cornerstone. Then you can also reduce the stiffness by giving an injection. The injection we call Botox. Botox is, you might know, Botox is a cosmetic, basically cosmetic injection, but basically it was initially used for ophthalmology, and then it came to cosmetology, then it came to neurology. And then we weaken the muscles. The muscles that are contracting excessively, we weaken the muscles so that it helps in their physio. That also we do under guidance.
So thank you so much for talking to Covai Post, Doctor. Thank you.
To get instant news updates, like the Covai Post page. Click on See First to view the news first. Also, in YouTube, subscribe to Covai Post channel to watch interesting news and videos.